Our next speaker today is Dr. Ronald Wapner. Dr. Wapner is a professor of obstetrics and gynecology, director of reproductive genetics, and vice chair of research at Columbia University Medical Center. Dr. Wapner?
Well, thank you, Mike. What I'd like to do in this session is talk about some of the things that we have learned from the introduction of microarray genomic technologies into prenatal diagnosis. From the standpoint of conflicts, I have none that are in conflict with any of the content that will be presented in this session. Interestingly, we frequently have a very arrogant attitude that we understand and know way more than we think we do. This is just from an article in Lancet in 1977 talking about the introduction of amniocentesis. Interestingly, one of the sentences from that article says that virtually all chromosomal aberrations can be detected by amniocentesis. Just call to your attention below what the state of karyotyping was at the time so that you can understand that we had just begun using banded karyotypes, and certainly we were just beginning to understand the chromosomal aberrations that could be identified. Over the last 30 years, actually over the last 40 years, we certainly have learned that there is a lot more information that can be identified both by karyotype and most recently by molecular cytogenetic techniques such as chromosomal microarray. Most people would agree that for prenatal samples, the resolution that we get from standard karyotyping is between 7 and 10 million base pairs. More recently, with the introduction of chromosomal microarray, we now have resolutions that in clinical practice is somewhere in the 300 to 500 kilobase range, but actually have a technology now where we can identify microdeletions and duplications as small as 30 kilobases. However, there's a number of questions about how we should use this information in clinical practice. As we were learning about the ability to interrogate the genome at smaller and smaller levels, we also have learned that there is a significant amount of very clinically relevant pathology. We now know that there are a number of microdeletion and microduplication syndromes with very significant severe phenotypes, such as Prader-Willi syndrome, Miller-Dieker syndrome, DeGeorge syndrome. We also have learned more recently that not only are there significant syndromes, but there also are other effects of microdeletions. And we know that smaller microdeletions in the 500 to 700 kilobase range can be associated with disorders such as autism, schizophrenia, and a number of other very significant clinically relevant neurocognitive abnormalities. This has led to the treatment or to the evaluation of children in the postnatal period by using microarray technology as the first-tier test for children who have neurocognitive difficulties, dysmorphic features, and those who also have developmental delay. In actuality, in many nurseries and children's genetic services, microarrays are now the first-tier test. However, there's significant questions about whether or not and how we move this genomic technology into prenatal diagnosis. And these questions call into discussion the differences between prenatal testing and postnatal testing. Certainly with prenatal testing, no matter how good we think our ultrasound is, we really never have a complete and accurate phenotype. There are limits to our imaging, and most importantly, we know nothing about the cognitive capabilities of the fetus. In addition, people use information very differently when it's obtained prenatally. Postnatally, we will use the information obtained from a microarray to make decisions about subsequent treatment and needs of that fetus. Alternatively, prenatally, this information is frequently used to make a decision of whether or not one will continue the pregnancy. Finally, the desires of the parents are different. Postnatally, the parents want to know why this happened and will it happen again, as opposed to prenatally, patients want us to use these genomic tools to assure them that they're going to have a normal child. Obviously something we can't do, but an understanding that's sometimes hard to have parents understand. Because of these differences, and because we need to understand how to use these new tools, we were funded all over 7 years ago now by NIH to do a prospective, blinded comparison of microarrays to what at the time was the standard prenatal test, which was karyotyping. The study was relatively straightforward. All patients having prenatal testing for any indication had the sample split, and a microarray was performed in one laboratory. Standard karyotyping was performed in another laboratory. Information went to a blinded or went to a single independent data coordinating center and then was compared. The results of this study, both from a scientific and also a clinical standpoint, really have given us some important guidance about introducing new technologies into prenatal diagnosis. So let's start talking about what we learned about structural anomalies. In this particular slide, we see the largest studies that have looked at microarray for the evaluation of pregnancies in which ultrasound has identified a structural anomaly. All of these pregnancies had karyotyping performed, which was normal. So the numbers we see illustrated here are the incremental information that microarray was able to give us. One of the remarkable things about this is how consistent each of these studies were, and our study, as did all of the others, demonstrated that in structural anomalies identified by ultrasound, in which a karyotype is normal, microarrays have positive, clinically relevant, these are only pathogenic and clinically relevant findings of around 6%. It varies, however, depending on the ultrasound finding. If there's an anomaly only in a single system, the additional benefit from the microarray was about 5.5%, whereas if there are multiple systems involved, not surprisingly, there was over a doubling of the likelihood that an array would give us clinically relevant findings. It also varied by which systems the ultrasound demonstrated a structural abnormality. As you can see, in some systems like the cardiac and facial abnormalities, despite the fact in some systems such as cardiac and facial abnormalities, despite the fact the karyotype was normal, 15% of patients had a copy number variant of clinical relevance. As you see, that actually falls significantly based on other organ systems. But interestingly, even pregnancies in which there is fetal growth restriction have a significant presence of copy number variance. In this particular slide, we review the 232 cases of cardiac defects. Of those, 130 had normal findings, and normal means that both the karyotype and the microarray were normal. 78 of those had whole chromosome aneuploidy, and 24, and as I pointed out, about 15% had a copy number variant. The remarkable thing is that when we look overall, now when we see a cardiac abnormality, 44%, or almost half of those cases with a cardiac defect, we now have a cytogenetic or a genomic etiology. I would think that as we move even into the future, in which we start, and some centers have, from a research standard, have started sequencing these cases, the number of cardiac defects or even other structural defects in which we will be able to give parents causative information will continue to increase. The value of this information can't be underestimated. On this slide, we look at 223 cases in which ultrasound showed a single ventricle. About 2/3 of these were a hypoplastic left heart. The others were single right ventricles. And if you look at the cases as they're differentiated here, those that had a pathogenic copy number variant compared to those that didn't, and you look at things such as the Bailey Psychomotor Development Index, it's clearly seen that the prognostic information given by a copy number variant is very important, because those that had a deletion had a remarkably lower PDI on the Bailey test than those that didn't. So from the standpoint of being able to give couples in which there's an ultrasound finding additional incremental information, the ability to get more detailed resolution of the genome becomes very, very important. Interestingly, the vast majority of the children that had the copy number variants associated with the single ventricle had no dysmorphic features. All children were evaluated by a clinical dysmorphologist, and only a very small percentage of those who had a deletion or a duplication were noted to have any dysmorphic features. So from physical examination, we're not very good at differentiating this, but indeed it certainly demonstrates the importance of this information. So with this in mind, let's move the question one step further, and a number of people have asked whether or not molecular karyotyping using microarray should become the primary tool for anybody having a prenatal diagnostic test. It certainly has higher resolution. It identifies the area of deletion or duplication much better, and there are a number of reasons that this may make sense. So in order to answer this, I have taken all the studies that have been published recently that had more than 1,000 cases. And this includes around 12,000 cases reported in the literature in which patients had prenatal diagnosis, in which the fetus was structurally normal, and they had a microarray performed. And as you can see, for all of these 10,000, just over 10,000 low-risk pregnancies, about 1 in 100 had a pathogenic copy number variant. This excludes any variants that are common benign or felt to be benign. These numbers vary from a low of around 1 in 200 to a high, which was our prospective blinded study, of around 1 in 63 structurally normal pregnancies were identified as having a clinically relevant copy number variant. I think the reason that this varies as time went on, there are different definitions between different laboratories, and we'll talk a little about this in a minute, about what one considers to be a clinically relevant finding. But it's important to realize that even in structurally normal pregnancies, there is a not insignificant frequency of these anomalies. One of the things that in prenatal testing parents care about the most are pregnancies that have the potential to cause significant neurocognitive impairment. So I took the cases from our study, and I just listed the frequency of those that have recurrent, well-defined, pathogenic copy number variants that are associated with neurocognitive complications. And even with that stringent definition, these occurred in about 0.8% of pregnancies, or 1 in 125. And you can see on this slide the relatively well-described recurrent copy number variants that we found. So this is something that one could, at least on the frequency of pathology, make a very good case that perhaps we should use this as our primary tool for invasive or for evaluation of invasive prenatal diagnostic samples. Now, one of the arguments that comes up with copy number variants for prenatal testing is, are there not some things, even mild neurocognitive difficulties that we should or should not be diagnosing in utero. And this question is only growing because as our genomic technologies continue to give us a much larger genotypic spectrum, we see a much larger phenotypic implications. But I think we really need to understand that at least prenatally, we no longer can say that we do prenatal genomic evaluation, and there's only two potential ways to use that information: continue the pregnancy or not continue the pregnancy. As the information increases and the spectrum of the phenotypes increase, we have to understand that what we really are doing is giving patients important information about the child in the pregnancy, and there are major advantages to having this information that do not necessarily include the need or the desire to terminate the pregnancy. So I think that the use of this information is obviously going to change. We have found from our discussions with patients, when we find many of these copy number variants, patients are very able to comprehend that these are not significant phenotypic consequences, and in many cases what they say is, thank you very much for the information. I will tell my pediatrician, and my child might need early intervention. We know for things like autism, etc., the earlier we're able to get a child on a therapeutic track, the better the long-term prognosis for potential learning disorders, etc. So again, I think one of the things we have learned, and we've learned this from patients, is they really are able to comprehend this information, and they really are able to use it to improve the management of the child after birth. However, no test or no genomic evaluation is without some difficulties, and there are two difficulties that we're all aware of. One is findings of unknown significance, and the second is the large variable expressivity. And over the past 5 to 7 years, we really have learned a lot about how to be inclusive and understand these and use them in prenatal testing. Certainly, findings of uncertain significance will always be there, but through a number of major efforts, we have developed large databases, both things like DBVAR, etc., which tells us a large number of benign variants, and other large collections with pathogenic variants, so that we can take, as illustrated here, populations of pregnancies or children that have phenotypic consequences, look at the frequency of copy number variants in that population, and compare it to the frequency in an unaffected population. So we have these large databases both on the internet and in the literature, etc. So we have gained a lot of information about how to evaluate this. If indeed we do not have sufficient information using those collections of data, we then have to move to the next step, which is looking at the genes involved and try to make an educated evaluation for the parents about what this might mean. But I think one of the things that all of us are aware of, that the ability to say that a specific gene might be deleted to make a really accurate correlation with the phenotype is still not as easy as we would like it to be, and we still need to continue to gather a lot of information to make this possible. However, I've taken the copy number variants of uncertain clinical significance from our study, which was performed in 2007. And as you can see, about 2.5% of cases had a variant at the time, which was felt to be of uncertain clinical significance. In 2012, we had the same exact laboratory and geneticists review the copy number variants, and from 2007 to 2012, because of these large collections of data, the frequency of variants of uncertain significance decreased by almost half, so that half of them were now able to be reclassified. As you can see, many of them were now classifiable as pathogenic, although a few were classified as likely benign. So the point here is that we are gathering rapidly significant information on the pathogenicity of variants, so that the number of variants of unknown significance will continue to decrease. But again, we still have a ways to go in order to gather more information so that we can really give patients the best prognostic evaluation as we can. The other thing that we learned is that in order to evaluate variants of uncertain significance, we really do need a team. And I think most centers that are using microarrays, when they have variants of uncertain significance, have a committee or a review group that they use even for clinical practice. It includes a geneticist, can include an obstetrician, a maternal fetal medicine specialist, and a laboratory person who then really sit down and talk amongst themselves and decide exactly how to present this to a patient. So in interpreting this information, it really does take a team approach, but certainly it's the best way to get patients the information that they need. We also have the question, and this is not just for copy number variants, it goes with sequencing and other tests that ultimately will be used both postnatally and prenatally, and that is, do we have to report all variants of uncertain significance to the patient? If you go by the credo that we should do no harm, there are certainly people, as illustrated here, that argue that there is no good that comes from telling somebody we have a result, but we have no idea what it means. On the other, and so that basically, based on that premise, maybe we shouldn't be giving the patients those information or those pieces or those results. Alternatively, there's the exact opposite group of people that say it's the patient's right to be given all of the information, and that we should be able to explain to them that we don't know that. One of the arguments that I've heard is that, well, if you tell them that you don't really have any idea what this means, but there's some problem with the child's DNA, that a number of patients will make decisions not to continue a pregnancy. Actually, in our experience, we have found, and from the study standpoint anyway, that patients are very capable of understanding uncertainty. They're able to understand we don't know, and actually very few patients didn't continue their pregnancies. So again, this is a debate that's only going to increase as more and more sophisticated technologies are used. The other issue is what about variable expressivity? Certainly when you make a prenatal diagnosis, it's very, very difficult to say to a patient, well, this is the genomic finding, and it could either be something very, very mild, or it could have a severe phenotype. That's actually more difficult than variants of uncertain significance. And on many of these cases, there's been concern that some of these genomic findings may actually have variable expressivity. They may not actually be penetrant. But I think also we have learned a heck of a lot over the past actually about 5 years or so. And an example of this is what is illustrated here, which is a 16p11.2 deletion. And there were 2 studies in 2008 describing that this was a microdeletion associated with autism. And the penetrance of this particular deletion for autism was felt to be around 15%. So certainly at that time you might say, well, this gives the pregnancy a predisposition to autism, and leave it there. By collecting much larger populations of patients, we've learned that there's a lot more information that we can give patients. And this is a work that was supported by the Simons Foundation, looking exclusively at 16p11.2 deletions. And they evaluated these kids both phenotypically and, both structurally, and also by doing IQ testing. And one can see that for autism spectrum disorder, indeed, there was about 15% that had that. So for that particular abnormality, one can understand that the penetrance would be said to be around 15%. But when these children were evaluated in much more detail, only about 6% did not have some developmental difficulty. So in this particular case, it was completely penetrant, but had a relatively wide expressivity, see phonology disorders, learning disabilities, etc. The other thing that was evaluated was the IQs were done on these patients, and in red are the IQs of the patients with the deletion. In blue are other family members, predominantly SIBs and parents. And when the IQs of these individuals were compared, there's very little question that having the deletion significantly decreases the IQ potential compared to other members of the family. As you can see, the carriers had an IQ that was 28 points lower than the particular non-carriers. So if we had basically used developmental delay by the classical definition of an IQ less than 70, there would have been a significant concern that this was incompletely penetrant and that most people did not have significant intellectual disability. Alternatively, with further evaluation, we now know that this is very variable in its expressivity, but most individuals with it will have some developmental impact. And the reason I talk about this is the kind of information that we need to help explain these findings to patients. And as we get larger cohorts with particular genomic findings, we'll probably see that the data and the information we can give parents is much more expansive, and that many of these are much more penetrant than we thought they would be. So finally, I think the question of, well, what should we tell parents prior to the procedure, and what is the pretest counseling that should be used? And there is no question that if you're going to use arrays as part of prenatal testing, describing it and discussing it with parents is imperative. This is not a 5-minute, this is what we're going to do. This means sit down with them and explain it in detail. However, if you think of the principles of what we need to discuss, it is no different than what we presently use for any prenatal evaluation. We need to talk to them about the importance of what the test can and cannot detect, and that the spectrum for microarrays is certainly wider than it is for karyotype. That findings of unknown significance may occur, but we already know that from karyotyping. As a matter of fact, there's 2 large studies looking at standard karyotyping, and the frequency of variants of unknown significance in that group was about 1%, which is not too different than what we're presently seeing with copy number variants. And third of all, genetic disease has variable expressivity. This is a credo that all of us know and have lived with. So the counseling for microarray, a lot of it is just going to be very, very similar to what we're already talking to patients about. There are, however, certain things that are unique to any genomic testing, and in this case microarray in particular, and that is that we could identify adult onset diseases, and this certainly would be a counseling issue if it's identified in the fetus, and so in some of these cases it will lead to identification of the same adult onset disorder in a pre-symptomatic parent. So that certainly can occur, and I think we need to understand how we explain that prenatally, and whether or not when we present this we should ask parents at that time whether they want to know that information. That is generally our practice. We tell them that these adult onset conditions can be identified, as can some abnormality in the parent, and if they don't want to know that, we're more than happy to withhold that information unless it is certainly a finding that has some therapeutic potential. All of these things should be discussed with the parent before testing is performed, and I think one of the real roles of a counselor is to understand the patient's threshold for uncertainty and the interest in information that would be difficult to digest and would cause problems. And I think if we could identify on a patient-by-patient level exactly what the patients want, I think that rather than strong yes or no guidelines, that's probably even a better way to evaluate how we should deal with this information. But we come to the gigantic question of who will and who has the time and can do this. To go through detailed counseling and then understand the patient's threshold for uncertainty, etc., takes a lot of time, and right now in many states genetic counseling is not being reimbursed. So it doesn't only take time, it basically takes non-reimbursed resources. The other thing that we learned is that we need some education. And this is a study that was done by Barbara Bernhardt from Penn, and she talked to counselors and she interviewed them through the NSGC, and she asked the counselors about their comfort with particular patient-related or care-related findings in prenatal diagnosis. In other words, how comfortable do you feel talking to a patient? And in this case, talking to a patient about a prenatally diagnosed Down syndrome, almost 100% felt comfortable with that. Providing genetic counseling about a normal prenatal microarray, they felt comfortable with that. But if you look down at the bottom, in the last three categories here, their comfort with helping a patient make a decision about terminating a pregnancy if there's an uncertain prenatal result, less than half felt comfortable with that. Providing genetic counseling about uncertain results or prenatal array findings, they didn't feel comfortable. So again, this points out that if we're going to counsel parents on this, we need to make the counselors very, very comfortable with this new information. And for all of us, it's difficult to transition from what we presently feel very comfortable with to new technologies that at times, particularly at their introduction into practice, will be difficult. This will only be done through education of patients, education of counselors, and education of healthcare providers. And in addition, we certainly will ultimately then be better able to educate our patients. In the future, there's a number of things that we really need to understand. Number one, we need additional studies that can help us evaluate what the best way to counsel a patient is. How do we balance the risks and benefits, particularly for diseases with much wider spectrum of phenotypes than we presently are used to counseling for? Second of all, we need better educational materials for all of us, including the patients. Third, and I think we're sometimes bad at doing this, we have to understand what our patients want. What is their balance between information and between risks of an invasive test, if that's what's involved, or risks of gathering information that they may not want to hear about. It's important to point out that there are now non-invasive prenatal tests that we're now using for diagnosis or screening for Down syndrome, trisomy 18s and 13s. Each of the companies have now developed the ability to identify microdeletions and duplications by NIPT. So we really have to understand, is that what our patients want? And then how are we going to deal with that information? There needs to be a cost-benefit analysis, which speaks for itself. There need to be standardized lab guidelines for interpretation and reporting of prenatal arrays, and ACMG has worked very hard in doing this, but still there's a lot more work that needs to be done. And then most importantly, we need long-term prospective studies of individuals who are identified with pathogenic CNVs and variants of uncertain clinical significance. We're very fortunate that NIH has continued to fund us to do that, and the second phase of our study is to actually identify in utero fetuses or pregnancies identified in utero with copy number variants and then follow them through childhood. And I've just put the website for anyone that has such a patient that they can refer those, and then we would be able to do this. This becomes increasingly important if we're really going to be able, and I think it's highly likely we will, to identify copy number variants on NIPT, knowing the long-term prognosis and the phenotypes in detail are going to be very, very important. So the need to have this information for prenatal testing is only going to increase. So with that being said, we've come a long way. I think those of us that spend a lot of time thinking about this have found this to be incredibly informative and helpful to our patients, such that 4 weeks ago, the American College of Obstetrics and Gynecology came out with a statement suggesting, or an opinion, suggesting that a microarray should be the first tier test in pregnancies identified with structural anomalies. So I think already we have transitioned to having a distinct indication for this in prenatal testing. Again, further evaluation is ongoing to decide whether or not it should be a first-tier test offered to all patients who are undergoing testing. So thank you.